It's good to see everybody, and I hope everybody is having a wonderful holiday season. As Ruth mentioned, I wanted to talk a little bit about a report card today with where we are in terms of HAIs, and also give you some different data that actually came to me last week via a colleague at CDC. And so I got permission to use some of his slides to share with you today, because I think they just really make a different type of impact than we've ever seen before. Dr. Alexander Kalin is the chief of the Prevention and Response Branch at the Division of Healthcare Quality Promotion at CDC. So you'll see a couple of his slides in here. He gave a phenomenal talk last week that we actually had for our APIC chapter. And there were a couple of slides in there that particularly I said, oh my gosh, this would be fantastic to share with the Grand Rounds group. And so he was kind enough to let us go ahead and do that. Dave, I just can't get over you're so distracting right now. So in terms of the SIRs, you can see that we have really lost a lot of progress. I'll sort of put it to you the same way he did in his presentation. He said essentially the last 10 years of gains that we've seen with the reduction of HAIs, for the most part, right, making a generalization, have been wiped out over the time period of COVID-19's pandemic. That's a pretty, dangerous thing to say. It definitely should open our eyes. It should open our eyes both as not healthcare providers only, but also as patients and consumers of healthcare services. And this is really pretty rampant. It's not just something that's affecting one particular area. You'll see a few things like C. difficile, for example, has actually done fairly well. But for the most part, we've actually lost a lot of the momentum that we already built. And so we've got some significant work to do. A lot of this goes back to staffing, attention to detail, really leadership support, and all of those different elements that make an infection control program so successful, or frankly, make it unsuccessful. And with the challenges that we're facing with staffing, right, it makes it even more difficult to put additional burdens or responsibilities on people, or frankly, to have more of an accountability-based discussion. I've got 2 or 3 graphs in here that are going to show you some pretty alarming statistics in terms of healthcare personnel movement. That was the first time I had seen that particular study, and so I wanted to share it with you today as well. So as I mentioned before, C. diff is one of the positive sort of lights out there. We've actually done fairly well. It's been pretty stagnant in terms of that, which is interesting because we know that a lot of antimicrobials were used during the COVID-19 pandemic, but luckily we haven't seen significant increases in C. difficile infection, which is good. Not to say we should take our eye off the prize, but it is definitely at least a positive beacon of hope in the terms of HAI reduction. So what about sort of the time period within COVID itself, right? So if you look at back to 2019, we had a fairly, stagnant set of SIRs, right? And so this was helpful because we were making progress. And in some cases, we were actually decreasing rates, which was good. And then, of course, COVID hit. And so we had all these different variables come in. We had a really honed in attention to isolation. We had, lots more COVID patients. We had a lot of respiratory type issues. We also had a lack of public reporting in some instances within HSN during that time period. And so the data is really being, sort of culled and analyzed now to determine where our gains and our losses were. And unfortunately, the significant losses that you see here are pretty substantial. I could tell in his voice when he was presenting this particular graph that you could just feel the deflation, right? And so, he in particular is a really straightforward person, a really straight shooter, excellent epidemiologist and an ID doc by background. And you could just really simply see that there was concern about this, right? Because we had worked so hard to build up these different coalitions and alliances and bundles and all the things that we were doing to reduce infections. And now that was all wiped away pretty much with a short period of time. So how does that translate in terms of mortality as well as hospitalized patients? So again, we've got some areas where we're not so bad that you can see here, and others where we are. When we think about this in terms of mortality and morbidity, if you stack onto that sort of COVID, right, then we can have some additional losses because those patients may already come in with a comorbidity that's significant by nature, and then of course they get COVID. On top of that, if they get like an MDR, this can be very, very detrimental to us as well. And so here you can see again some additional data that shows the overall change from the 2019 to 2020 data points. They're getting ready to release, I believe, in the second quarter of next year, the 2021 data. So I don't anticipate, and really what they anticipate, it's be very similar. So we'll continue to see those losses. Now, the question becomes, at least in my mind, is how do we move forward from here, right? What are the things that we can do to influence positive change? How do we sort of use this as our new baseline, because that's what it is, right? And realize that we're essentially 10 years behind where we were. And so we've got to sort of start with that mindset of what are the things that we did that worked then? What were the things that didn't work? And then how do we deal with in today's sort of tenuous staffing circumstances? Right. And so one of the things that I thought was fantastic was he looked at this particular study from Dr. Snyder, and it was really looking at both CNAs and environmental services. And they were talking about the greatest barrier or challenge to preventing COVID-19 in your facility. And you'll see that it was really around staffing shortages, right? No surprise there. Now, if we sort of extrapolate this outside of the hospital market and look at our colleagues in skilled nursing, this becomes even more difficult because we know that in skilled nursing, the challenges of staffing and also just getting the right staff member, particularly a CNA, which is providing the majority of the care for those residents, is going to be very challenging. It's going to be problematic. And so that's a big, big issue for us as well. Leadership support continues to be something that is typically ranked, but you'll notice that on the EVS side, that was not an area that they sort of felt was lacking. And I think that's pretty telling. Right. So it tells us in the nursing sort of track, we have a little bit of an opportunity for improvement. And so that's definitely something to be aware of. So let's take it a little bit of a step deeper. So what if you look at lack of PPE and lack of education or training, right? Again, if you look at the beginning of the pandemic versus where we are at this time, you can see big changes, right? And that's certainly good. So at least we have availability of supplies, and people do know what to do, or at least they perceive that. Now, I will tell you one of the limitations of the study was they didn't evaluate whether someone was properly using, for example, PPE. It was just really the availability of it. And so again, we all know that if you have PPE, it doesn't matter how great it is or how perfect it is. If it's not perfectly worn, right, and it's not worn according to the manufacturer's instructions for use, or it's not fit tested, for example, then it's not going to be as effective as desired. So one of the things that they really talked about was sort of the overall changes that occurred during the first year of the pandemic. And these were just a few of the samplings that I thought would be most representative of the audience for today. And so you can see that we've got a lot of room and work to do here, a lot of room to grow, right? Now, a lot of this is going to extrapolate not just to the infection within the patient, but then it goes back into our overall principles for antimicrobial resistance, right? So how do we make sure that we're not only looking at this from an HAI reduction standpoint, but are we really tying this strategically back into all of our other programmatic efforts? And so I'd encourage us, especially if you're looking at your annual plan and your risk management, right, to sort of think differently, right? Where are we with our rates? How is our population changing? How have our services changed? And really, what has changed within our culture and our dynamic? If you're running a very skeleton staff, which many of us are, then that is really going to change the way that you can impact change. And frankly, what the sort of expectations can be. Now, that being said, the patient doesn't care what our staffing is. We all know that. My little brother, who's a malpractice attorney, doesn't care what our staffing is. Their expectation is safe, reliable, and efficient care every single time. They don't care what's happening behind the black curtains. What they want to make sure of is that we're doing our job and we're doing it effectively. And so knowing this information, again, is a starting point to say, we've got opportunity for improvement. We know what our baseline is. We've done it once before, and we can do it again. How long that will take, I'm hopeful will be greatly shortened because of all the different learnings that we've got. We've got better data systems now. We have better surveillance, and we really understand, I think, infection control on a cultural level a little bit differently. Now, that being said, let's play devil's advocate. How have we done with hand hygiene, despite all of the lessons learned, all of the science, all of the products, all of the different tools and resources that we have available to us, right? We don't have a good handle on that. And that's really one of the most basic elements of infection control that we have. So I say that to say it's really about finding the happy medium, the sweet spot, if you will, for doing what's right for our patients, doing it within the context and resources that we have, but we can never be afraid to do something just because we don't have resources. Ruth and I, for example, have worked on a particular hot topic related to ultrasound disinfection. And it's a topic that we're both pretty hot and passionate about for obvious reasons, because there is a substantial patient risk. And often we're met with resistance of, well, we can't do that because, and usually the answer is we don't have the time or it would cost too much, right? In a court of law, right, that's not going to be an acceptable answer that's going to be defensible, nor is it an acceptable patient safety response. And so we can't make excuses for why we can't do what was right for the patient. And we also can't ignore a problem simply because we don't know about it. And if there's something that Ruth has taught me over the years, the absence of data is not the absence of problem. And I think that is such a great reminder of that when you start to flip over the rocks, you start to find what you look for. And so just because we put our blinders on and we walk down a straight and narrow path doesn't mean that these things are not in existence. We just simply have to go look for them. So what about antibiotic prescribing, right? Again, we're seeing, changes in these rates, which is definitely something to be aware of, right? And if you look at 2021, we're almost back to where we were at 2019. And so in 2020, you'll see a pretty marked drop off. Part of that was the decreased use of antibiotics, but also one of the things that was noted in this particular data point was that there was a decrease in outpatient visits. And so that certainly would make sense that if you see less patients in the outpatient setting and more we're moving to telehealth as an example, then you would see a change here. So we've got lots of things to work on that are all closely tied together, should I say. So let's talk for a second about healthcare personnel shortages. This is pretty fascinating to me. If you look at the yellow, it's a little bit hard to see. I apologize. I had to sort of scale the graph. The yellow is the low likelihood of reducing their hours. And then the blue is the high likelihood of reducing their hours. So if you look at sort of this, the first one on the left is, in the next 12 months, and the graph on the right is in the next 24 months. And so if you look particularly at nurses, right? Nurses, for the most part, with the exception of the graph on the left, you'll see some pretty tight similarities there. And on the one under 12 months, you'll see physicians, APPs really, and nurses were all closely, and then other clinical were very closely related. If you look in the next 24 months, right, 40% of nurses have a high likelihood of leaving their current practice. That should be absolutely alarming, not only to us, right, we're all aware of this, but to healthcare leaders and executives, public health professionals that might be looking at staffing situations across the regions in which they support, right? This is going to greatly impact our future pandemic capacities and our readiness, because if we are losing bedside providers, particularly those that are in nursing, that means we don't have the ability to care for patients. It used to be that we had beds, but, we had nurses, but we didn't have enough beds. Now we have beds, but we don't have enough nurses. And so this is a pretty alarming statistic that came out of a data point that was collected by Mayo Clinic in 2021. So just draw that attention, right, particularly to the nursing staff. And this is hopefully a wake-up call to chief nurse executives. I know the Nursing Executive Association, that's part of the American Hospital Association, has really looked at sort of resiliency data, but resilience really deals with the team that you have. And so we've got to figure out a way to not only deal with the team that we have, but also be able to recruit people to come into a field. I don't really talk to people now that say, I'm excited to go into healthcare. I don't hear that from young people anymore like I did. I'm sure there's lots of different reasons for that. But certainly one of them is healthcare is not seen as this sort of sexy profession that it used to be. And certainly it is perceived in a lot of cases as dangerous, right? Not just from an infectious disease standpoint, but, if you go work in an ER, for example, there's a high likelihood you might be assaulted by a patient. And so there's lots of different variables that go into this. And so we've got to look at this sort of beyond the 24 months. This is sort of the data point we have, but what's going to happen probably in the next 5 years? What's the sort of retirement? Are people going to take early retirement? What are we going to do to replace not only the bodies, but also the institutional knowledge that those people bring to the table? And then I wanted to talk for a second about AJPs, or AGPs, excuse me. So when you think about aerosol generating procedures, this is an area where you have a lot of, I would just say, confusion. If you think about the very beginning of COVID, right, we heard a lot of talk about, well, you shouldn't do this because it's going to be dangerous to the healthcare workers. And certainly the profession of healthcare, right, needs to be protected. We have to have healthcare workers that are safe and are able to come to work in order to care for our patients. That's a no-brainer. But that doesn't mean that we can't provide safe and reliable care using different means, right? And so that's an area that is really, really important for us. So if our standard of care, for example, for a respiratory patient, let's say somebody who's got really chronic COPD or bronchitis, or they're coming in with an acute asthma attack, we need to be giving them a breathing treatment, right? And just because a breathing treatment produces aerosols doesn't mean that we can deviate away from that standard of care. The other thing that we're starting to learn is that the procedure itself is not near as risky as the other basic things that we do, like talking or coughing, right? So if I cough, right, 400 times increase in sort of that aerosol production. Just simply here by talking, 35 times, right? Those were not data points that were really widely known at the time that CDC gave the recommendations, right? And so again, we've got to go back to a more common sense-based approach to really look at our high-risk exposures. Note that we still need to be compliant with standard of care, but also still give the patient what they need in a safe and reliable manner, right? We can't deviate away from that. And we certainly have lots of PPE options as needed in order to do that. One of the things that I think is exciting is there is a lot of talk about standardization. So we've talked about standardizing infection ratios, which we've done, right? We've got NHSN data, which we've done. They're going to continue to improve that, hopefully. We need better access to reporting that's more real time, right? Not just at the health system level, but at the national level. CDC needs to be able to act quickly when they see things, and sometimes they can and sometimes they can't, depending upon the circumstance. But one of the areas that we can do better quickly, right, is on standardization of products that we offer. So if we look at PPE, for example, PPE is regulated by the Food and Drug Administration. There's a lot of input that comes from NIOSH, right? You may have not have heard of that term before, but it's essentially a research arm of CDC that really works very closely on occupational health-related issues and does a lot of research for OSHA also. And so you'll see a lot of the OSHA documents will cite NIOSH standards or NIOSH materials or reference points. One of the things that came from that was, how do we get masks to actually be more standardized? You know, is a mask a mask a mask? And the answer was no, particularly in terms of fit testing. And we found that, of course, that was a big issue during COVID because we couldn't rely that a large was a large was a large, or a medium or a medium or a medium. And so when we went to, do substitutions and we had other products that came in to our health systems, it really put the healthcare worker at a disadvantage. And it certainly put a massive undue obligation on occupational health, and in some cases, infection control, to do fit testing on all these different masks, right? And so one of the things that ASTM is doing, which is the method sort of writer, if you will, for different types of products, is they've developed this standard that really looks at the performance in terms of a couple of different things. How does it filter, right? How breathable is it? Does it have any type of leakage? And then how is it labeled? And the labeling, to me, is one of the key things. The filtration is pretty straightforward, right? We know what level of filtration we're trying to achieve, but how something is labeled and designed gives us a higher level of compliance in an emergency, right? If we can say, hey, we can source these types of masks or these types of gloves, whatever it may be, it allows us to be very quick and methodical in our approach to infection control, but also deal with supply chain challenges that we have. If you turn on the news this morning, I was watching the news at about 6 this morning, and now we have a Tylenol shortage, right? Because a lot of our ibuprofen and also acetaminophen is made in China. And so again, here we go back to critical classes of drugs are not within our control here. And so that's going to make things like amoxicillin, which we're already experiencing issues with, on a critical shortage list. We're now seeing the same thing for things like Tamiflu as well. And so we've got lots of opportunities from a regulatory perspective for approval. So there are things that we can do to move the needle. Ruth has been heavily involved with her work with HICPAC with CDC on the core practices for infection control. They just did a recent update, actually November, to this, and I can't stress enough how important that simple document is. I really call it the common sense approach to infection control. If you do these core things all the time, it's really going to make a significant improvement, not only in the reduction of risk to the patient, but also there's a component in the core practices to reduce the risk to us, right, as healthcare workers. No one wants to take care of a patient and have a substantial risk that was completely preventable. We need to get better about doing the right thing and doing it proactively. And so a lot of this goes back to understanding transmission-based precautions and really knowing how to sort of adapt those within our system, right? There's a lot of controversy right now, of course, with long-term care with some of the new requirements coming out of CMS with that. And, one of the things that was brought up actually at this meeting that I attended last week was, well, there's all these new regulations, for example, with long-term care, but there's no new money. And so that's where there's a disconnect between the science and the regulatory and payer perspective. And we have to do better about working the legislative process, getting involved as professionals at that state and hopefully national level, and driving some of these changes so that we are all wanting to do the right thing, right? I don't remember the last time I talked to somebody who said, I don't want to do the right thing. We all want to do the right thing. That's why we're here. What we do need help with, though, is sort of having the support, the infrastructure, and the finances and leadership support to move that needle forward. And so as we look at that more common sense approach, for example, if somebody has diarrhea, right, we know we need to do. We need to take those contact-based precautions. We need to use laboratory testing more appropriately and not practice defensive medicine. We need to use our resources more appropriately and also manage our patient flow to the degree that we can. One of the other things too is communication, especially amongst facilities. If we see a discharge, for example, from acute care to long-term care or vice versa, or some type of transportation, it's no different than when EMS calls the hospital ER and says, we're bringing in a patient. This is sort of what's going on. Here's what we've done so far. Here's the resources we might need as an example. You don't want somebody showing up at your emergency department with a stroke alert and you didn't activate the stroke team because you didn't know. The same is true here. We need to do better about sharing information, really looking at a standardized approach. And there are forms for transfer that are readily available on the CDC website to do this. And they were originally designed for transfers from acute care to long-term care and vice versa. But we can really use this anywhere. Good discharge planning or transfer care is going to be an important element of the work that we do to reduce infections for sure. And lastly is, I think, probably the most important. What we do is not a siloed approach, right? It is definitely an area that requires a true team-based modality to allow us to be successful. It requires collaboration. It requires communication. It by no means says that we're going to agree all the time. But what it does say is that we'll always put the patient and our safety first, that we'll always try to do the right thing, that we'll always be transparent in our approach, and that we will never give up on doing the right thing. Right? Just because it takes too much time or it's too expensive, that doesn't negate that it's the right thing to do. And so when we look at in sort of infection prevention, it's really not a rocket science, right? It is by far a straightforward, common sense, scientific approach to just doing the right thing and exercising your brain power, right? What is hard is changing culture, changing minds, changing hearts, to really understand the data at a different level where you can truly impact change, to work with other stakeholders to make sure that we're working simultaneously and not against each other, right? Those are all elements that are very much missing, I think, in a lot of modern infection prevention programs. And the same is true with patient safety and healthcare quality. The difference is, I think that healthcare quality and patient safety, because they're typically embedded within the healthcare quality department, you'll see a lot more resources that might be there as well. We've definitely seen a shift with IPs either being closely aligned or in some cases directly reporting to healthcare quality here over the last few years. And, to me, that's not necessarily a bad thing. We are driving quality throughout our organization, and quality is not just data, it's not just surveillance, but it's also process measures. Like, how are we putting in central lines? What are we doing with some of these basic metrics? And let's not forget our colleagues at public health that allow us to understand at a more granular level the epidemiology and then drive those practice changes, things like antimicrobial stewardship with our amazing colleagues and pharmacists, right? So these are all things that we have to sort of bring to the table. I would encourage you to, use this data if you want, share it with your colleagues. It definitely, to me, was very eye-opening. Particularly the staffing. The thing that definitely hit me in the head with like a 2x4 was how many nurses are getting ready to leave the profession. Right? That is an alarming statistic that we should all be quite concerned about for just the future of care in general. And that is going to impact acute care for sure, but long-term care could be really devastated by that with the limited nursing staff that they can already get today. So definitely something to consider. So with that, Dr. Kerker, I'll stop and see if there's any questions from the audience, and we'll go from there.
Thank you very much. You brought up a number of questions and issues that I think are important for the infection prevention community. First of all, we've talked about understanding the ASTM standards and really then the AMI standards as well that you mentioned with the ultrasound. And this is a whole area in infection prevention where I think we're particularly weak in both understanding some of the resources and also some of the technical aspects of the equipment and items that we use as part of everyday work. So as we're thinking now on what did we learn from 2022 and what do we need to do for 2023, do you have maybe some ideas on how IPs can learn a little bit more about ASTM or AMI or some of these additional organizations that may be really not yet on our table, on our consideration? What are some maybe quick things, quick learning that we might be able to do to augment our knowledge?
So I think one of the easiest things, right, that's free is to get on their listservs, right? Go on their websites, get on their listservs, because that is typically something that you can access for free. Each of these organizations has great resources. AMI, for example, has an excellent risk management class on medical devices that I've been fortunate to take. That is an invaluable tool and resource for IPs. The challenge is, to your point, that facilities don't support it. It's a very expensive course. It's about $1,500 to go for 3 days. But I will tell you that, you're learning from leaders in medical device safety, post-market surveillance, the FDA's there. It's an invaluable tool in your armamentarium. But if we don't support it from a financial standpoint and allowing people to go, it makes it really impossible. There are lots of good free resources available. CDC's got some on the TRAIN network. It's not the most friendly learning management system, but it's out there and it's free. There are some programs out there that exist that are through the different associations, but most of the associations, as we all know, charge. One area that I think is particularly helpful, and I would encourage you to get involved with, is healthcare value analysis. So if you can stop something that's bad coming in the door, before it ever gets implemented, it really saves us a lot of time and energy. And so what I found historically is that, yes, the IP sits on the value analysis committee, but they typically don't have a really granular level understanding of what value analysis is and how to more formally contribute to the process up front, and frankly, to be a more strategic mindset at that particular table. And so there are resources available for that. We're actually getting ready to do a program after the first year. I'll drop the website for their association in there. It will be free. So if you want to join it, feel free to sign up for it. And it's got CEs attached to it, but it's all about infection prevention and value analysis. And so I think that that's a great place to start, because it gets you exposure to asking the right questions, looking for the right information, sort of deciphering through the BS that's out there, right, and the different marking collateral, but really to think more in a risk management component of, how do I make strategic evidence-based decisions with the knowledge that I have? And I think the piece is, a lot of the IPs are not given the knowledge necessary or exposed to the knowledge necessary to ask these more strategic questions, right? And once we do that, it gets to a different level of leadership within our profession. It also elevates the role, but it really prevents harm. And I think that's the key that we're trying to get after.
So you're talking a lot about the evolution of the role of the IP. And I think that we will see that, again, more in 2023 about what that changes. And as you mentioned risk management, then I was reminded about ECRI, that, how to maybe go to the individual risk management department at your facility and ask, are they a member? And can they get then access to some of those materials that are in the library? I know that's what I did at Norton Healthcare, to go, call the risk management department and say, how can I get, have access to some of these documents? Because again, if you try to join as an individual, it's just, it's cost prohibitive and it doesn't make sense. But in all likelihood, someone in the organization has a membership. If they participate and are part of the Kentucky Hospital Association, the Patient Safety Institute will, I think, provide them with access. So finding these new areas of resources, I think, may be something that we want to really look at for 2023. I don't know if you have thoughts about some others that we may want to also look out for?
I mean, I think all of those are highly relevant. The underlying theme, though, for me is leadership, right? How do we allow, and leadership is I think a generic term that we throw around. Having been exposed to some pretty cool programs with the American College of Healthcare Executives, and I recently got my fellow status, which was something that was, I would just say, impressively hard to do. I have a different appreciation for it, and I also can see the gaps. It's nice to sort of see, okay, here's where the executives are sitting, and here's where our profession is sitting. And there's this massive sort of distance of miles between the two that doesn't need to exist. And so I think a part of that is exposure, creating that executive presence, which we need to see, and infection prevention, really mastering the presentation of data to the board so that we can really show the impact of the work that we're doing, because we don't want to be data collectors or surveillance collectors or NHSN people. We want to be true influencers of change. And that's what an executive is looking for in another executive. And so I think that its leadership is going to have lots of different tentacles, if you will, of the octopus. It's going to be change management. It's going to be executive presence. It's going to be data analysis, understanding finances, which I hate finances, but I took courses to try to master it because people around me were talking in terms I didn't understand. And I thought I can't survive if I don't learn the language. It's just like medical terminology. We can't talk medical terminology to our patients because they don't understand what we're saying. But I think a lot of this is going to have to be driven from the ground up, sadly. I've always been a fan of not allowing anyone else to drive my career or my goals. I drive them myself. I own them. It's my responsibility. And with that comes investment. And I've sadly spent a lot of money on that. But I can definitely look at tangible return on investment. And I think we need to have those conversations with our leaders and say, I need to go to this program because here's what I can bring back to the facility. Here's the strategic plan and sort of implementation that I can do around risk management or medical device safety or whatever it may be. And I think it'll start to change the tide with the way leaders support infection control.
I think your mention of leadership will be, again, an important theme as we enter 2023, because I think one of our initiatives for the training center in 2023 will be to have an early 2023 boot camp focused on what do you mean by change management and change leadership? How will we take that? And then toward the end of the year, when we have maybe boot camp 2023B, A and B, that may be on more of the content that, content update for infection control. But I think, your thoughts about, infection control is both an orientation and an onboarding element for organizations, because people need to understand how does this work from a systems perspective across the organization, and then what are the infection control do's and don'ts and how-tos, and why do you do that? Those are separate, and I think then become components of a leadership program. So you have really brought some additional thoughts for us as we close out 2022. And I want to thank you not only for all of the work that you have done with our state throughout 2022, but what I hope that you will have time to continue to do as we look at the next year and as we continue our improvement initiatives. So thank you very much. I didn't see any particular comments in the chat, David. Santa, was there anything else that we needed to bring up? No. All right. Well, thank you, Dr. Garrett, as always, and thank you for the participants being here. And I look forward to working with everybody in the new year. Have a great and Merry Christmas and holiday.